Okay, let's unpack this. Welcome to the deep dive. Today, we're embarking on, well, a really vital journey into the interconnected world of vascular, bone, and rheumatic conditions.
Hmm.
And this isn't just about memorizing facts or, definitions. Our mission is really to peel back the layers, to understand the why behind the what, especially for you as nursing students. You absolutely need to master these areas to provide, well, truly exceptional, life-saving patient care.
Yeah, what's truly fascinating here, and something we'll definitely emphasize throughout this deep dive, is just how incredibly interconnected these physiological systems are.
Yeah.
A problem in one area, let's say vascular health,
Yeah.
it often ripples into bone health, or it impacts the inflammatory response in ways you might not immediately expect.
Right, it's never just one thing in isolation.
Exactly. So we're going to connect the dots between those sometimes subtle symptoms, the underlying pathophysiology, and crucially, those critical nursing actions you absolutely need to take.
Mhm.
Our source material for today is a comprehensive nursing review. It's specifically designed to solidify that foundational knowledge.
Okay.
So think of this as your essential kind of high-yield guide, not just for navigating your exams, but also for confidently understanding the complex patient presentations you'll encounter, really every single day on the clinical floor.
Absolutely. Our mission today is to distill the most important nuggets of knowledge from these, let's face it, complex areas, making sure you grasp the critical signs, the vital interventions, and the rationales that are, well, absolutely fundamental to your nursing practice. We'll be going into as much detail as possible, trying to make sure you walk away well-informed and really ready to apply this knowledge. Let's jump in.
Okay, so we're starting our deep dive today with peripheral arterial disease, or
Sure.
PAD.
This is a condition you will undoubtedly encounter frequently in practice, and it directly impacts a patient's perfusion.
Mm-hmm. Vertically.
So when you're assessing a patient, what are those physical signs that should immediately sort of scream to you that something is critically wrong with their arterial blood flow?
Yeah.
What are those crucial visual cues that signal decreased circulation that a new nurse will absolutely cannot miss?
Yeah, that's a great question. When you lay eyes on a patient with suspected PAD, you're essentially looking for the body's subtle yet um, powerful screams for help because of that reduced blood flow. The first things that typically jump out are changes in the skin and hair on the affected limb.
Okay.
You'd expect to see a limb that has pale, often shiny skin.
Genie, right?
Yeah, and this isn't just like a cosmetic detail. It's a direct visual cue of decreased perfusion. That vibrant oxygenated blood just isn't reaching the capillaries properly, making the skin look dull, sometimes taut, and almost blanched. It's missing that healthy blush of circulation.
I see. So the shine is almost from the skin being stretched and poorly nourished?
Kind of, yeah.
Yeah.
And building on that, you'll often notice hair loss on the legs. Now, this might seem minor to some, but it's a really significant indicator. It directly connects to the decreased nourishment reaching those hair follicles because of the poor circulation.
Mm.
Without adequate blood flow, the follicles simply atrophy, and hair growth slows down or stops altogether. So you end up with smooth, often hairless skin over the affected areas.
Makes sense.
And finally, a fundamental, palpable sign, something you can feel, is a cool temperature to touch. When you lay your hand on that limb, it feels noticeably cooler than maybe the other limb or the rest of the body.
Right.
The body struggles to maintain warmth in that extremity when the arterial supply is compromised. Because, warm blood is what normally regulates body temperature, and it's simply not reaching that tissue efficiently. These are all very direct indicators of insufficient arterial perfusion.
That distinction about cool skin is vital. But let's clarify a classic red herring some new students might consider. Why wouldn't we typically see warm, flushed skin in PAE? That suggests something entirely different, doesn't it?
Oh, absolutely. That's a critical distinction. Warm, flushed skin actively suggests increased blood flow. That points you towards things like venous congestion, maybe inflammation, or even an infection.
Okay.
So if you see warmth and flushing, your mind should immediately shift to a completely different set of potential underlying problems. It's really the opposite of arterial insufficiency.
Got it. And speaking of other long-term changes, what about something like thickened toenails? Are those as immediate an indicator of perfusion issues as the others?
That's another good point. While thickened toenails can occur with chronic PAD, they aren't as direct or immediate indicators of decreased perfusion as the other three signs we just discussed: the pale skin, the hair loss, the coolness. Thickened toenails are more a result of chronic poor nutrition to the nail bed over a really extended period, which affects how the nail grows.
Ah, so longer-term consequence.
Exactly. So while you definitely note them as part of a comprehensive assessment, they don't signal those acute critical perfusion issues in the same way. The pale, shiny, cool, hairless skin, those are the acute screaming signs you need to catch early.
Okay, so you've walked into a patient's room, you've spotted these signs, that cool, pale, perhaps hairless limb. Your nursing gut is telling you PAD. In that critical moment, it's your absolute non-negotiable priority nursing intervention for this patient. What's the foundational action?
Right. Once you suspect PAD based on those signs, your absolute cornerstone of nursing care, the single most important intervention, is performing neurovascular checks consistently and meticulously.
Neurovascular checks. Okay.
This is absolutely paramount because PAD directly compromises circulation, and the viability of that affected limb literally hinges on you consistently assessing the adequacy of blood flow. You're monitoring constantly to prevent tissue damage, potential limb loss, or other severe complications that stem from prolonged ischemia, that lack of oxygen.
So it's about early detection of worsening flow.
Precisely. Imagine if the blood flow becomes completely blocked. Every single minute counts towards saving that tissue. Other interventions, they're important in general patient care, like daily weights for fluid balance, or encouraging cough and deep breathing for respiratory health, maybe monitoring bowel sounds.
Yeah, all standard stuff.
Right, standard stuff. But they are simply not the most important action for directly monitoring and managing the immediate and acute risks associated with PAD itself. The direct threat to the limb's viability is what demands your constant neurovascular assessment.
And when we talk about neurovascular assessment, we're inevitably talking about the 6Ps. Expert, this is a classic for a reason, isn't it?
Oh, absolutely.
For future nurses listening, mastering the 6Ps for a neurovascular assessment. It isn't just about memorizing a list. It's really about performing a systematic, comprehensive check of circulation and nerve function that guides your immediate action. Can you walk us through each of these critical Ps and explain what vital clue each one offers us?
Definitely. The 6 Ps are truly a critical mnemonic. They guide a rapid yet incredibly thorough assessment of both circulatory and neurological status in a limb, especially when you suspect impaired blood flow. Let's break them down. First, we have pain. This is often the initial symptom and the most distressing one, particularly pain with activity. It indicates ischemic pain caused by that lack of oxygenated blood.
Okay, pain.
Next is pulse. Here, you're assessing the presence, the quality, is it strong, weak, thready, and the regularity of pulses distal to the affected area, so further down the limb. This directly tells you about the strength of the blood flow getting past any potential blockage.
Pulse. Got it.
Then pallor. This refers to the skin color, specifically its paleness. As we just discussed, this directly indicates a lack of arterial blood flow.
Pallor, right.
Fourth is paresthesia. Here you're assessing for any abnormal sensations like numbness or tingling. This is a crucial sign that can point to nerve ischemia, meaning the nerves aren't getting enough blood supply.
Paresthesia, numbness, tingling.
Exactly. Following that is paralysis, which signifies a loss of motor function. Can the patient move their toes or foot? This is a more late and very severe sign, indicating significant nerve and muscle ischemia that demands urgent intervention.
Paralysis. Okay, that's a late one.
A very late and serious one. And finally, polar, which refers to the skin temperature, specifically coldness. Again, this directly reflects poor blood flow to the extremity. Coolness.
Polar. Makes sense. Pain, pulse, pallor, paresthesia, paralysis, polar.
That's it. Systematically checking each of these 6 elements allows you to rapidly assess the circulatory and neurological status. It tells you if immediate interventions are needed to preserve the limb and prevent irreversible damage.
Okay, here's a common scenario you'll definitely hear on the floor, and it's a hallmark sign for PA. A patient reports leg pain when walking, maybe in their calf, but then it consistently gets better when they stop and rest. Expert, what's that specific symptom called, and what deep understanding does it give us about their condition?
Yes. That specific pain pattern where pain in the legs occurs consistently during activity and is reliably relieved by rest that is known as intermittent claudication.
Intermittent claudication.
It is virtually diagnostic for peripheral arterial disease. The pathophysiology behind it is quite direct, and once you grasp it, it really illuminates the whole problem. During activity, your muscles demand significantly more oxygenated blood to do their work.
Right. Makes sense.
Well, in a patient with PD, their arteries are narrowed by plaque buildup. That means they simply cannot supply enough blood to meet that increased metabolic demand during exertion. This difference between supply and demand leads to ischemic pain in the muscles, essentially. The muscles are starved for oxygen.
So the pain is literally the muscles crying out for oxygen.
Exactly. Then, when the patient rests, the muscle's demand for oxygen decreases. This allows the limited blood flow that is getting through to catch up, and the pain subsides. And this is a critical distinction to make. It's not a venous clot, like a deep vein thrombosis, which presents differently, usually with swelling and warmth. Nor is it a lung clot, a pulmonary embolism, or bone softening from osteomalacia. Intermittent claudication is specifically about that predictable arterial insufficiency during exertion. It's a classic sign of compromised arterial flow.
Okay, now let's shift our focus. We've talked arteries, let's move to veins. Let's talk about deep vein thrombosis, DVT. This is another condition you will frequently encounter in clinical practice, and it's one with very serious, potentially even life-threatening implications if it's not managed effectively. Expert, can you break down the key risk factors that kind of converge to lead to DVT formation? What is that classic triad we need to understand?
Yeah, when we delved into DVT risk, we immediately think of something called Virchow's triad.
Virchow's triad, okay.
This isn't just a mnemonic to memorize. It's really the fundamental framework for understanding why blood clots form in veins, particularly deep veins. This triad consists of three primary factors that individually, or even more dangerously in combination, significantly increase a patient's risk. The first leg of the triad is circulatory stasis.
Stasis, so slow blood flow.
Exactly. It just means blood pooling or slow blood flow. This is incredibly common in situations involving immobility. Think about long-haul flights, prolonged bed rest after surgery, or even just someone sitting for extended periods in a chair. When blood isn't moving efficiently, clotting factors tend to accumulate in one area, creating a prime environment for a clot to begin forming.
Makes sense. What's the second part?
The second factor is vessel damage, or sometimes called endothelial injury. This refers to any injury or trauma to the inner lining of the blood vessel itself. This can happen from surgery, direct physical trauma like a fracture, or even irritation from medical devices like central venous lines.
Ah, okay.
When the vessel wall is damaged, it triggers the body's natural clotting cascade, creating a site where a clot can start to initiate.
Right, like a rough spot for things to stick to.
Precisely. And the third, equally vital factor is hypercoagulability.
Hypercoagulability. So the blood itself is more likely to clot.
Exactly. It's an increased tendency for the blood to clot. This can be due to genetic predispositions that some people have or certain underlying medical conditions like cancer. It can also be acquired through factors such as specific medications, hormonal therapies like birth control pills, or even pregnancy.
Wow, okay, so stasis, vessel damage, and hypercoagulability.
That's Virchow's triad. And the presence of even one of these factors increases the risk, but when you see combinations of two or all three, say, a post-op patient who is immobile, the risk for DVT formation just elevates exponentially. This makes it a really critical area for astute nursing assessment and aggressive prevention strategies like early ambulation and compression devices.
Definitely. So once a patient actually has a DVT and they're placed on anticoagulant therapy, let's say warfarin, which requires careful monitoring, you're going to be looking at their INR. What's the therapeutic range you're generally looking for to ensure that the medication is effective, doing its job, but also not causing excessive bleeding? What's that precise sweet spot?
All right, the INR, or International Normalized Ratio, is crucial for warfarin management. For DVT prevention or treatment, where the goal is to adequately thin the blood to prevent new clots or the extension of existing ones, an INR between 1.5 and 2.0 generally indicates therapeutic effectiveness.
1.5 to 2.0.
Yeah, that range isn't arbitrary. It's carefully chosen because it represents that critical balance. You need sufficient anticoagulation to prevent further clot formation, but you want to minimize the risk of excessive bleeding. Just for context, an INR of about 0.8 to 1.2 is considered normal for someone not on anticoagulants.
Okay.
Values higher than 2.0, and especially if they get above 4.0, indicate an increasing risk of hemorrhage. The blood is too thin, and the patient is at significant risk for bleeding complications. So maintaining that precise 1.5 to 2.0 range is absolutely crucial for both patient safety and the overall efficacy of the treatment. It's a lab value you must pay very close attention to.
Definitely. Speaking of anticoagulants, heparin is another common one, especially in acute care settings. You need to know it inside and out, but you also, crucially, need to know when not to give it. Expert, which patient scenario would make you absolutely halt and say, hold on, this patient should not receive heparin right now due to immediate safety concerns?
That's a critical safety check. When it comes to heparin, patient safety is paramount. And there's one critical contraindication that you as a nurse must be immediately aware of: a significantly low platelet count.
Low platelets. Thrombocytopenia.
Exactly, thrombocytopenia. Platelets are absolutely essential for the blood's natural clotting process. They form the initial plug when there's vessel injury. If a patient's platelet count is already dangerously low, administering an anticoagulant like heparin drastically increases their risk of severe, potentially uncontrollable hemorrhage. You're essentially stripping away their body's last line of defense against bleeding. It creates a direct and very dangerous interaction. Other conditions like, say, COPD, diabetes, or hypertension, while they certainly impact overall patient management, are generally not direct contraindications for heparin in the same way. They don't pose that same immediate, life-threatening bleeding risk related to heparin's mechanism of action as severe thrombocytopenia does.
Okay, that's a really important distinction. Low platelets hold the heparin.
Absolutely. It's a critical decision point for patient safety.
Now, for you as a nurse, knowing the single biggest patient education, what's the greatest concern, that life-threatening complication we're trying to prevent, above all else, in a patient with a DVT?
The greatest concern, the most dreaded and potentially life-threatening complication for a patient with a DVT, is unequivocally a pulmonary embolism, or PE.
PE.
The mechanism is tragically straightforward but devastating. A piece of the DVT, which we then call an embolus, can break off from the deep vein, usually in the leg or pelvis. Once it detaches, it gets carried by the bloodstream, travels up through the right side of the heart, and eventually lodges in the pulmonary arteries within the lungs.
Blocking blood flow to the lungs.
Exactly. When this happens, it effectively blocks blood flow to a portion of the lungs, severely impairing gas exchange. This often leads to sudden shortness of breath, sharp chest pain, a rapid heart rate, and a potentially catastrophic decline in oxygenation. A PE is a true medical emergency requiring immediate recognition and intervention, because it can be fatal if not addressed very quickly.
And it's different from other clots, right?
Absolutely. This is distinct from a stroke, which involves a clot blocking blood flow in the brain, or a myocardial infarction, a heart attack, which is a blockage in the coronary arteries supplying the heart muscle, or even an arterial ulcer, which is a skin lesion caused by poor arterial flow. The direct anatomical connection between a DVT in the leg or pelvis and the pulmonary circulation makes PE the primary complication we are most vigilant about preventing and detecting.
Okay, moving beyond DVT, you'll also encounter patients with other venous conditions, like varicose veins. They're quite common. Expert, what's a key practical intervention you can teach your patients to help prevent these, or at least manage their progression and the associated symptoms like aching or swelling?
Yeah, for preventing or managing varicose veins, one of the most effective and accessible interventions you can teach your patients is the consistent use of compression stockings.
Compression stockings, okay.
These stockings work by applying external graduated pressure to the legs. That means the pressure is strongest at the ankle and gradually decreases as you go up the leg. This external pressure gently squeezes the veins, which in turn significantly helps to improve venous return back towards the heart, working against gravity.
So it helps push the blood back up.
Precisely. By preventing blood from pooling in the lower extremities, they reduce the stress on those venous valves, which might already be a bit compromised. It minimizes the likelihood of blood backflow and the subsequent distension and tortuosity, that twisted look that characterize varicose veins. It's a physical, mechanical intervention that can make a significant difference in symptoms and potentially slow progression.
And other things wouldn't work as well.
Right. Other options like, say, increasing sodium intake would actually increase fluid retention and potentially worsen swelling, not improve venous return. Applying heat to the legs would cause vasodilation, potentially worsening blood pooling. And avoiding leg exercises would promote circulatory stasis, which is exactly what we want to prevent in venous conditions. So compression is key.
So if compression stockings help by supporting the veins, then what's actually causing these varicose veins to develop in the first place? What's fundamentally going wrong inside the leg that leads to their formation?
The fundamental cause, the root issue of varicose veins, lies squarely in incompetent venous valves.
Incompetent valves.
Yeah. Think of your veins, particularly in your legs, as having a series of one-way valves.
Yeah.
Their job is to prevent blood from flowing backward, ensuring its steady return to the heart against the pull of gravity. When these valves become damaged, weakened, or simply fail to close properly, becoming incompetent, they allow blood to pool and flow backward within the vein segment below them.
Ah, so gravity wins.
Essentially, yes.
Yeah.
This pooling causes the veins to become engorged, twisted, tortuous, and visibly distended under the skin, which is what we recognize as varicose veins. It's strictly a venous issue. It's a structural and functional problem of the valves themselves. It's not a problem with blocked arteries or calcium deposits or low platelet counts. It's all about the compromised integrity and function of those crucial one-way valves in the veins.
Okay, that makes sense. Let's shift now to a more specific and quite serious vascular condition, Berger's disease. This condition is often linked to a very specific lifestyle factor, and it's something you absolutely must address with utmost importance if you encounter it. Expert, if you have a patient with Berger's, what's the most crucial risk factor you need to address with them? The one thing that will make the most significant difference in their prognosis and disease progression.
Without a shadow of a doubt, the single most crucial risk factor to address with a patient diagnosed with Berger's disease is cigarette smoking.
They're smoking.
It's not just a risk factor. It is the main, paramount, most important causative factor and the strongest predictor of disease progression. Smoking doesn't just damage the lungs, it exerts powerful vasoconstrictive effects, directly narrowing blood vessels throughout the body. More importantly, it directly damages the lining, the endothelium of blood vessels, particularly the small and medium-sized arteries and veins in the extremities. This leads to inflammation and clot formation.
So it attacks the vessels directly.
Yes. This ongoing damage and persistent vasoconstriction are precisely what drive the relentless progression of Berger's disease. It leads to severe pain, chronic ulcers that don't heal, and ultimately, far too often, amputations of fingers and toes. Therefore, facilitating and emphasizing absolute smoking cessation is the single most impactful intervention you can engage in for these patients. It's non-negotiable for managing this disease.
Wow, okay. So knowing that smoking is absolutely paramount, what other, perhaps less obvious lifestyle factors might also worsen Berger's disease by creating additional challenges for circulation?
That's a good follow-up. Beyond smoking, several other lifestyle factors can indeed worsen Berger's disease because they, too, contribute to vasoconstriction and reduced blood flow, which is the core problem. Caffeine, for instance, is a well-known vasoconstrictor. It can cause blood vessels to narrow temporarily.
Right, like coffee.
Exactly. For a patient with already severely compromised circulation due to Berger's, this can further exacerbate their symptoms and reduce blood supply to those already vulnerable extremities. Stress is another significant, often overlooked factor. High levels of stress can trigger sympathetic nervous system responses, that fight-or-flight response, which leads to widespread vasoconstriction throughout the body.
Huh.
Again, further reducing blood supply.
The stress connection.
Yeah. So both caffeine consumption and high stress levels, in addition to the primary culprit of smoking, contribute to worsened circulation and the progression of this debilitating disease. It's not really about specific nutrient intake like protein or potassium. In this context, it's about avoiding anything that further constricts those already compromised vessels.
Okay. Another interesting and sometimes challenging vascular condition you might encounter is Raynaud's disease. Expert, how would you describe this to a patient, particularly focusing on what they would experience? The sensations and the visible changes they might see in their hands or feet.
Right. When explaining Raynaud's disease to a patient, you describe it primarily as an episodic condition. It involves poor circulation, typically in the hands and feet, that causes very characteristic color changes. What happens is that the small arteries supplying blood to the skin, especially in the fingers and toes, go into these temporary exaggerated spasms. This usually happens in response to cold temperatures or sometimes emotional stress.
Spasms in the arteries.
Exactly. This sudden vasospasm drastically reduces blood flow to the area. This leads to a classic triphasic color change. It often happens in 3 stages. First, the digits might turn stark white or pallor, due to the severe lack of blood flow. Then they often turn blue or cyanotic as the remaining oxygen is depleted from the tissues in that area. And finally, as blood flow slowly returns after the spasm subsides, they might turn bright red or rubor.
White, blue, red. Wow.
Yeah, it can be quite dramatic visually. And along with these striking color changes, patients often experience uncomfortable sensations, numbness, tingling, and intense coldness in the affected digits. It's crucial to differentiate this from, say, lack of blood flow to the heart muscle, angina mi, or thickening of brain arteries, stroke risk, or inflammation of venous valves, phlebitis. Those are entirely different processes.
Got it.
Raynaud's is specifically about these episodic vasospasms in the extremities, often brought on by identifiable triggers like cold or stress.
Okay, now let's pivot. We're moving from vessels to the world of bone health, starting with osteoporosis. This is a condition you will see frequently, especially in older adults. But expert, who's at the greatest risk for developing osteoporosis based specifically on medication use, rather than just age or gender. This seems like a crucial nursing assessment point.
Yes, absolutely crucial. When we specifically look at medication-related risk for osteoporosis, the patient at greatest risk is undoubtedly one who is taking corticosteroids long-term.
Corticosteroids, like prednisone.
Exactly, like prednisone, often used for chronic conditions such as COPD, asthma, or autoimmune diseases.
Huh.
Long-term corticosteroid use is a very significant and extensively documented risk factor for accelerated bone loss. These powerful medications interfere with the body's ability to absorb calcium from the gut. That's one mechanism. And crucially, they also inhibit the activity of osteoblasts. Those are the cells responsible for building new bone.
So less build.
Right. And simultaneously, they can increase the activity of osteoclasts, which are the cells that break down bone.
And more breakdown. Not a good combination.
Not at all. This unfortunate imbalance leads to a net progressive loss of bone density over time. It makes bones increasingly brittle and highly prone to fracture, even from minor stress or trauma. While other conditions like hypertension, type 2 diabetes, or asthma managed with just an albuterol inhaler don't carry that same direct high risk for bone loss from the medication itself, chronic corticosteroid therapy directly and profoundly impacts bone metabolism. It significantly elevates osteoporosis risk.
Yeah, definitely something to flag in a medication history.
Absolutely. A critical medication history detail for nurses.
So when you have a patient with osteoporosis, what key symptoms might they report? Or what physical findings might you observe that would make you strongly suspect something specific is happening to their bones, particularly their spine? What are those telltale signs?
When you're assessing a patient with known or suspected osteoporosis, two hallmark symptoms that should immediately make you suspect specific bone involvement, particularly in the spine, are chronic persistent back pain and a noticeable progressive loss of height over time.
Loss of height, really?
Yes, these are classic signs of pathologic fractures or compression fractures, especially in the vertebral bodies of the spine. Remember, osteoporosis makes bones incredibly brittle and weak, so even minor stresses like bending over, lifting something moderately heavy, or sometimes even just daily movements can cause these vertebral bodies to collapse or compress. This leads to chronic, often dull, aching back pain that might not have another obvious cause.
And the height loss?
Over time, multiple cumulative compression fractures can cause a progressive loss of overall height. And it can also contribute to the development of that stooped posture, sometimes called a kyphosis, or colloquially, a dowager's hump. These symptoms are quite distinct from, say, symptoms of bone cancer, kidney stones, or Raynaud's. They point directly to the structural compromise of the skeletal system due to severe bone density loss.
Okay, now let's talk about a medication critical for osteoporosis management. Alendronate, brand name Fosamax, belongs to the bisphosphonate class. There are very specific instructions you absolutely must teach your patients for taking this medication to ensure its effectiveness and maybe even more importantly to prevent serious complications. Expert, what are those non-negotiable teaching points?
Yes, the teaching for alendronate and bisphosphonates in general is incredibly precise, and it's primarily because of their potential for severe esophageal irritation. It's highly caustic. You absolutely must instruct patients to, number one, take it with a full glass of plain water. Not juice, not coffee, not milk, plain water.
Full glass of water. Okay.
This is essential for proper dissolution of the pill and critically to ensure it travels quickly down the esophagus and doesn't get stuck, which could cause localized burning. Number two, it must be taken on an empty stomach. Typically first thing in the morning, at least 30 minutes before any food, drink, or other medications.
Empty stomach. Got it.
This is because food, especially calcium-containing products like milk or fortified orange juice and even some minerals, can significantly interfere with its absorption, drastically reducing its effectiveness.
Right.
And number three, and this is absolutely critical for patient safety, patients must remain in an upright position for at least 30 minutes after taking the medication.
Upright for 30 minutes, no lying down.
No lying down, no bending over, ideally not even reclining significantly. Sitting upright or standing is best. This instruction is vital to prevent the medication from refluxing back up into the esophagus. If it does, its highly caustic nature can cause severe irritation, inflammation, esophagitis, and even painful ulceration.
Wow, okay, so full glass of water, empty stomach, stay upright for 30 minutes.
Exactly. And emphasizing why you don't take it with milk interferes with absorption, or right before bed, lying down increases esophageal risk, is also key. This teaching literally prevents serious patient harm. It's that important.
Definitely sounds like it. Let's talk about another bone condition now. Osteomalacia. How is this best described, and what's its primary cause? Particularly when we see it in children where it has a different name. What's the fundamental problem here?
Osteomalacia is best described as bone softening. This is a crucial distinction from osteoporosis, which is loss of bone density, making bones brittle.
Softening versus brittle. Okay.
Right. In osteomalacia, the fundamental problem is a defect in the mineralization of new bone matrix. This means that the bone tissue itself, the protein scaffold, is being laid down, but it isn't being properly hardened with essential minerals, primarily calcium and phosphate. This leads to bones that are weak, pliable, and flexible, rather than brittle like in osteoporosis. They can bend under pressure.
And the cause?
In terms of its primary cause, it almost universally stems from a severe vitamin D deficiency.
Vitamin D?
Yes. Vitamin D is absolutely crucial because it enables the body to absorb calcium from the gut. Without enough vitamin D, even if a person is consuming sufficient calcium, that calcium won't be adequately absorbed and subsequently deposited into the bone matrix to harden it. This inadequate mineralization makes the bones soft and prone to bowing or deformities.
And in children?
In children, this condition is specifically known as rickets. It often results in very visible deformities like bowed legs or knocked knees, along with generalized bone pain, muscle weakness, and sometimes delayed growth. So it's distinct from bone hardening or bone brittleness due to corticosteroids or a bacterial bone infection like osteomyelitis. It's specifically about soft bones due to lack of mineralization, usually from vitamin D deficiency.
So if vitamin D deficiency is such a major issue leading to osteomalacia and rickets, what practical advice can you give on the food front? What foods should you recommend to patients to boost their vitamin D intake, especially for those who might not get much sun exposure, which is another source?
That's right. Sun exposure is important, but diet plays a key role too. To effectively boost vitamin D intake through diet, you should recommend a variety of readily available foods. Key sources include egg yolks. They contain natural vitamin D. Many dairy products, especially milk and some yogurts, are fortified with vitamin D in many countries, making them an excellent and accessible source.
Fortified milk, yeah.
Fatty fish are particularly good natural sources, things salmon, tuna, mackerel, sardines. They are packed with vitamin D.
Okay, fatty fish.
Even certain meats, like beef liver, contain some vitamin D. And additionally, many breakfast cereals are fortified, providing another avenue for dietary intake, especially helpful for kids. So recommending these dietary sources, ideally combined with sensible sun exposure, which stimulates the skin's own vitamin D production, provides the essential building blocks for healthy bone mineralization and is crucial in preventing conditions like osteomalacia and rickets. It's really about a combination of diet and lifestyle.
Okay, let's move into the complex and often debilitating world of rheumatic diseases now, starting with rheumatoid arthritis, or RA. This is a systemic inflammatory disease that you'll certainly encounter. Expert, what's an early, often subtle sign of RA that you might observe, or perhaps that a patient might report, even before the significant, obvious joint involvement really begins?
That's a key point about RA because it's a systemic inflammatory autoimmune disease. Its early signs aren't always confined just to the joints. In fact, one of the early, more generalized symptoms you might observe or hear about from a patient is actually a low-grade fever.
A fever, interesting.
Yeah, maybe not high, but persistent low-grade. This systemic inflammation, the body essentially fighting itself, can also manifest as pronounced generalized fatigue, like really wiped out fatigue, a sense of malaise or just feeling unwell, and sometimes unexplained loss of appetite or slight weight loss. These systemic symptoms often precede the overt classic joint symptoms like swelling, prolonged stiffness, and pain in multiple joints.
So it can feel like a general illness at first.
It can, yes. And this is an important distinction to make because severe joint deformities, or those large, noticeable rheumatoid nodules you sometimes see on fingers or elbows, those are typically much later signs of the disease. They reflect chronic, ongoing joint damage. And muscle paralysis, conversely, is generally unrelated to the early RA presentation. So a persistent low-grade fever, coupled with that significant systemic fatigue, can be an important early red flag hinting at the onset of this chronic inflammatory process.
Okay. Now, when you are assessing the hands of a patient with RA, maybe a bit further along, what specific finding would you expect to see that's characteristic of this inflammatory condition? What's a visual clue in the hands that tells you this looks like RA?
When assessing the hands of a patient with rheumatoid arthritis, one specific finding you might expect to see is that inflammatory swelling, often described as sort of boggy or soft swelling. And sometimes you might see what is referred to as Baker's cysts, although those are more common behind the knee. But more broadly in the hands, you'll see synovial fluid collections or prominent swelling, especially around the knuckles, the MCP joints, and the wrists.
Swelling around the joint.
Yes, RA causes chronic inflammation of the synovium, which is that soft tissue lining around the joints. This persistent inflammation leads to an overproduction and accumulation of synovial fluid. This forms fluid-filled sacs or just noticeable, often symmetrical swelling around the affected joints, including those in the hand and wrist. This is a crucial distinction to make from Heberden's nodes. Remember those?
Yeah, the bony bumps in OA.
Exactly. Heberden's nodes are those bony enlargements of the distal finger joints, and they are characteristic of osteoarthritis, the degenerative kind, not rheumatoid arthritis. Bluish discoloration isn't typical, and swelling only in the wrists wouldn't be the full picture either. It's typically that inflammatory swelling affecting multiple joints, often symmetrically, that signals RA.
Got it. So, to truly understand RA, you really need to grasp its core pathophysiology. Expert, what's fundamentally happening inside the body, maybe at a cellular or immune level, that causes all this pain, inflammation, and eventual damage in rheumatoid arthritis?
The primary pathophysiology of rheumatoid arthritis is that it's a systemic inflammatory autoimmune disease. That autoimmune part is key.
Autoimmune, the body attacking itself.
Precisely. What this means, in essence, is that the body's own immune system, which is supposed to protect us from foreign invaders like bacteria and viruses, mistakenly identifies its own tissues as foreign and launches a misguided, sustained attack. In RA, this attack primarily targets the synovium, that soft tissue lining around the joints. This misguided immune response leads to chronic, persistent inflammation within the joints. This causes the characteristic pain, the prolonged stiffness, especially morning stiffness, and the swelling.
And the damage.
Over time, this uncontrolled, persistent inflammation doesn't just stay in the soft tissue. It can actively erode the cartilage covering the bone ends and eventually even the underlying bone itself. This leads to irreversible joint destruction, instability, and significant deformity. So it's crucial to understand it as an autoimmune process. It's not simply localized wear and tear of cartilage like an OA. It's not caused by simple calcium deposits or a genetic lack of synovial fluid. It's the immune system turning against itself, leading to widespread inflammatory damage that impacts not just the joints, but can have systemic manifestations throughout the body too, affecting organs like the lungs, heart, or eyes in some cases.
Okay, that autoimmune nature is really key. Now, NSAIDs, non-steroidal anti-inflammatory drugs, are commonly prescribed for RA patients. Expert, what's the primary purpose in managing the disease? What are they actually doing for the patient? And perhaps more importantly, what are they not doing?
Right. NSAIDs are definitely a cornerstone for symptom management in RA. Their primary purpose is to reduce inflammation and pain. They work by inhibiting specific enzymes, primarily KOX enzymes, that produce prostaglandins. Prostaglandins are key compounds in the body that promote inflammation, pain, and fever. So NSAIDs effectively help manage that inflammatory process and significantly alleviate the pain associated with RA. This improves patient comfort, allows them to function better, and improves mobility.
So they help with the symptoms.
Exactly. They help with the symptoms. However, and this is a really crucial point for nursing students to internalize, NSAIDs are symptomatic treatments only. They help manage the symptoms, but they do not in any way cure the underlying autoimmune disease. And critically, they do not prevent the progressive joint deformity that RA can cause over time.
Ah, okay, so they don't slow down the disease itself.
Correct. Preventing joint deformity and slowing disease progression typically requires other classes of medications, specifically the disease-modifying anti-rheumatic drugs, or DMARDs. Medications like methotrexate or biologic agents. These target the underlying autoimmune process more directly. So, NSAIDs improve quality of life by managing symptoms, but they are not disease-modifying. That's a key distinction in RA treatment strategy.
Very important distinction. Now, many RA medications, especially those DMARDs you just mentioned, work by targeting the immune system, which often leads to immunosuppression. Expert, what's the most important, truly critical piece of teaching you need to give a patient who is starting on these potentially immunosuppressing medications? What do they absolutely need to know to stay safe and healthy?
This is an absolutely critical safety point, probably one of the most important for patients on many RA medications, especially biologics and some traditional DMARDs. The most important teaching you need to provide is to emphasize diligent infection prevention. Specifically, you should advise them, and make it very clear, to try and stay away from large crowds and people who are obviously sick.
Avoid crowds. Why is that so critical?
Because immunosuppression significantly compromises the body's ability to mount an effective immune response. It makes patients much, much more susceptible to catching infections, viruses, bacteria, even fungal infections sometimes. Avoiding exposure to these pathogens, particularly in crowded environments like shopping malls, concerts, public transportation, or even large family gatherings during flu season, is paramount for their safety.
So it really lowers their defenses.
Dramatically.
Yeah.
Their immune system simply can't fight off bugs like it used to. So while taking medications with food or avoiding certain dietary items might be relevant for other drugs, the primary overriding concern with immunosuppressants is that heightened risk of serious, potentially life-threatening infection. Vigilance about infection signs and avoiding exposure is key.
Okay, let's move into some orthopedic and surgical considerations now, specifically starting with post-operative recovery after a right femoral bypass. This is a major vascular procedure we touched on earlier with PD. Expert, what's your absolute non-negotiable priority assessment for this patient immediately post-op? What are you checking first and foremost?
Right. After any major vascular bypass surgery like a femoral popliteal or femoral tibial bypass, your absolute priority assessment, the first thing you zero in on, is checking for adequate perfusion distal to the surgical site.
Distal perfusion, so checking the foot.
Exactly. This means meticulously assessing the pedal pulses, the dorsalis pedis, and posterior tibial pulses on the affected limb. You're also assessing skin color, temperature, capillary refill, sensation, and movement in that foot. The entire goal of that bypass surgery was to restore blood flow to an ischemic area lower down in the leg. Ensuring that the new graft is patent, meaning it's open and working and effectively delivering blood flow to the extremity, is absolutely paramount.
Why is it so critical immediately?
Because you need to prevent immediate ischemia, tissue damage, or a catastrophic failure of the graft itself. A clot could form in the new graft very quickly. You'll be using those 6 Ps we discussed earlier for PIAD, but checking for the presence, the quality, strong, weak, absent, and comparing those pedal pulses to the other leg, or the pre-op baseline, is the single most important indicator of graft patency and successful reperfusion.
So it tells you if the surgery actually worked.
In the most immediate sense, yes. Other assessments like urine output, temperature, or respiratory rate are certainly important parts of general post-op care, but they don't directly tell you if the bypass has achieved its primary limb-saving goal of restoring distal circulation. That pedal pulse check is job number 1.
Okay, that makes perfect sense. Now, let's circle back briefly to arthritis, because differentiating osteoarthritis, OA, from rheumatoid arthritis, ORA, is absolutely key for nursing students. Expert, how would you explain the fundamental difference in how they present, especially regarding their characteristic pain and movement patterns? This is where a lot of students get tripped up, so let's make it crystal clear.
Yes, this is indeed a common point of confusion, but once you understand the core underlying pathology of each, the clinical differences in presentation become much clearer and easier to remember. The fundamental distinction between osteoarthritis, OA, and rheumatoid arthritis, ORA, regarding pain and movement is this. OA pain typically improves with rest, while RA pain often improves with movement.
Okay, OA improves with rest, RA improves with movement. Let's break that down.
Right. Osteoarthritis, remember, is primarily a degenerative wear and tear condition. It's like the cartilage in your joints, which acts as a shock absorber, is simply wearing down over time due to mechanical stress, age, or previous injury. So, with OA, the pain tends to worsen with activity and weight bearing because there's less cushioning, leading to more friction and stress on the joint. And consequently, it usually improves with rest because you're taking the pressure off that damaged joint.
Makes sense, like an old car part wearing out.
Kind of, yeah. Rheumatoid arthritis, on the other hand, is fundamentally an inflammatory autoimmune condition. Its pain is driven by active inflammation. Therefore, RA pain is typically worse after periods of rest or inactivity. This is most notable in the morning, what we call morning stiffness, which can be quite prolonged, sometimes lasting for an hour or even longer.
Morning stiffness is classic RA, right?
Very classic. But as the person starts to move throughout the day, the joints often loosen up, and the pain and stiffness can actually improve with movement. This is thought to be because movement helps to circulate inflammatory fluids away from the joint.
Interesting. So movement helps clear out the inflammation somewhat.
That's the idea. So this distinction, OA pain, worse with activity, better with rest. RA pain, worse after rest, stiffness, better with movement, is critical because it highlights the underlying nature. OA is mechanical breakdown. RA is active inflammation. And just to reinforce, OA is degenerative, not primarily inflammatory. RA is inflammatory and systemic, often affecting multiple joints symmetrically, not just large or small ones exclusively, although it often starts in smaller joints of the hands and feet.
That's a really helpful way to differentiate them clinically. So if OA is about cartilage wearing down, what's truly happening inside the joint that causes all that pain beyond just the feeling of it? What's the precise mechanism of that wear and tear pain?
In osteoarthritis, the core issue, the precise mechanism driving that painful wear and tear, is essentially the loss of that protective articular cartilage. This cartilage normally covers the ends of bones within a joint. It's smooth, slippery, and acts like a natural shock absorber and lubricant, allowing the bones to glide effortlessly against each other during movement.
Like a cushion.
It's exactly a natural cushion. In OA, this vital cartilage gradually wears away. It thins, it becomes rough, it frays, and eventually, in severe OA, it can disappear entirely in certain areas. When this happens, you get bone-on-bone contact.
Ouch.
Yeah. Imagine two rough, unlubricated surfaces grinding directly against each other instead of smoothly sliding. This direct friction between the bones causes significant pain, stiffness, and a severely reduced range of motion. It can also trigger inflammation in the surrounding tissues and lead to the formation of painful bone spurs, called osteophytes, around the joint margins as the body tries to stabilize the unstable joint. So it's not primarily about inflammation filling the joint, though secondary inflammation can occur, or calcium deposits, or an immune attack like an OA. It's the direct, often agonizing result of that protective cartilage cushion being lost, leading to bones rubbing directly against each other.
Okay. And when you're doing a physical assessment specifically for OA, what specific bony growths or nodules on the fingers would you look for that are considered characteristic visual hallmarks of this condition?
Right, for osteoarthritis, during a physical assessment of the hands, you would specifically look for distinct swelling or nodules on the finger joints. Particularly, you're looking for what are known as Heberden's nodes and Bouchard's nodes.
Heberden's and Bouchard's nodes.
Yes, these are very characteristic bony enlargements, not soft tissue swelling like in Arati. They occur due to the underlying degenerative process of OA, the cartilage loss, and the subsequent bone remodeling and overgrowth. Heberden's nodes are located at the distal interphalangeal DIP joints. Those are the joints closest to the fingernails. Bouchard's nodes, which are a bit less common but also characteristic, are found at the proximal interphalangeal PIP joints, the middle joints of the fingers.
BIPs and PIPs. Got it.
These hard bony nodes are direct physical manifestations of the OA process. This is another crucial differentiator from RA, where, as we said, you might see softer, boggy swelling, synovial cysts, or deformities like ulnar drift. But these specific bony nodes are the classic sign of OA in the fingers.
Excellent distinction. Now, shifting gears slightly to general patient assessment, because you'll care for many older adults in your nursing career, regardless of specialty. Expert, what's the most concerning and often the earliest finding for you to spot if you suspect an infection in an older adult, because it's often not the classic high fever we might expect in a younger person?
You're absolutely right. This is such a critical point for geriatric nursing, and something every nurse needs to be aware of. In older adults, infection can present very differently, often much more subtly than in younger populations. And a fever, while it can occur, is often blunted or even entirely absent, especially early on. The most concerning and often the earliest reliable indicator of infection in an older adult is a sudden change in their level of consciousness or mental status.
Change in mental status, like confusion.
Exactly. This can manifest as new-onset confusion, disorientation, increased lethargy or sleepiness, unusual agitation, or just a sudden unexplained change from their baseline cognitive function. Their family might say, they're just not acting like themselves today.
Why is that the first sign often?
Well, their body's immune response might simply not be robust enough to mount a significant fever, or their thermoregulation might be impaired due to age-related changes. The infection puts a significant physiological stress on their already somewhat fragile system, and the brain is very sensitive to these stresses, often showing the effects first.
That makes sense.
So, while a mild fever or fatigue can certainly occur, a significant and acute change in mental status is a major red flag that demands immediate and thorough investigation for an underlying infection. Think UTI, pneumonia, sepsis, common culprits in this population. It's a critical, sometimes subtle, cue that their body is under significant physiological stress from an infection.
Okay, let's dive into some more advanced orthopedic concepts now. For you caring for a patient after a hip replacement, total hip arthroplasty preventing complications is absolutely paramount. Expert, what's the single most important instruction or device you can utilize, especially in the early post-op period, to prevent dislocation of that brand new hip? This is a core post-op teaching and safety point.
Yes, after a hip replacement, preventing dislocation is the absolute priority in the early stages. And the single most important instruction or device to achieve this is the consistent use of an abduction pillow when the patient is in bed.
The abduction pillow, that wedge between the legs.
Exactly. It's that specialized foam wedge, sometimes with straps, that's placed between the patient's thighs. It's specifically designed to keep the patient's legs separated and maintain the hip in a position of abduction, meaning the legs are spread slightly apart and often slightly externally rotated. This position effectively prevents two critical movements that are known to put the new hip joint at high risk for dislocation, especially with certain surgical approaches. Those movements are hip adduction,
Crossing the legs.
right? Crossing the legs or even just bringing the knees too close together. And the other is excessive hip flexion, typically bending the hip beyond 90 degrees. Without this abduction pillow maintaining that safe position, even simple, seemingly innocuous movements like rolling over incorrectly in bed or leaning forward too far to reach something could put that new hip at risk of popping out of its socket.
So it's a physical reminder and barrier.
Precisely. Therefore, diligently educating the patient and their family and ensuring the consistent use of this pillow whenever they are in bed or sometimes even when sitting up in a chair early on is vital for maintaining the integrity of the surgical repair and preventing a very painful and potentially damaging complication that might require another surgery. Crossing legs or deep hip flexion are absolute contraindications early on.
Got it. Abduction pillow is key. Now let's talk about gout again. That sudden, excruciating joint pain, often occurring abruptly, especially waking someone up at night with pain in the big toe classic podagra. Expert, what's the precise underlying cause of this intensely painful condition? What's going on at a microscopic level that triggers such an acute, severe attack?
Yeah, that classic presentation of sudden, severe, monoarticular, usually one joint pain, frequently affecting the metatarsophalangeal joint of the big toe, often starting overnight, is highly indicative of an acute gout attack. The underlying cause is the accumulation and subsequent deposition of uric acid crystals within the joint space.
Uric acid crystals.
Yes. Gout is fundamentally caused by hyperuricemia, persistently high levels of uric acid in the blood. Uric acid is a normal byproduct of purine metabolism, found in foods like red meat and seafood. When uric acid levels become too high, either due to the body overproducing it or, more commonly, the kidneys under-excreting it, it exceeds its solubility limit in the bloodstream and tissues. This leads to the formation of tiny, sharp, needle-like crystals called monosodium urate crystals.
Needle-like. Ouch.
Exactly. These sharp crystals then precipitate out of the fluid and deposit within the joint space, often in the synovial fluid or lining. The body perceives these sharp crystals as foreign invaders, triggering an intense neutrophil-mediated inflammatory response. It's a full-blown immune reaction that results in the characteristic redness, swelling, intense heat, and severe pain of a gout attack.
Yeah.
So it's not an infection or calcium deposits, that's pseudogout, or an autoimmune attack on the synovium like an RA. It's specifically this uric acid crystal deposition and the resulting acute intense inflammation that defines a gout attack.
Okay. And what medications are commonly used to treat these acute gout attacks, or longer term to prevent them from happening in the first place? What are our go-to pharmacological interventions?
For managing gout, you'll commonly encounter two main categories of medications addressing different phases. For chronic gout management, meaning preventing future attacks, the primary medication is often allopurinol.
Allopurinol for prevention.
Right. Its role is prophylactic. It works by inhibiting an enzyme called xanthine oxidase, which is involved in producing uric acid. By reducing the overall production of uric acid in the body, the goal is to lower the blood levels below that crystallization threshold, thus preventing those painful deposits from forming in the first place. There are other similar drugs too, like febuxostat. Colchicine, on the other hand, is often used specifically for treating acute gout attacks right when they happen.
Colchicine for acute attacks.
Yes, it works differently. It interferes with the inflammatory response to the uric acid crystals that are already there. It helps to rapidly alleviate the severe pain and swelling during an acute flare-up. It's most effective when started very early in an attack. And of course, NSAIDs like ibuprofen or naproxen can also be used for acute pain and inflammation during an attack. Sometimes corticosteroids are used for severe attacks too. But allopurinol for prevention and colchicine for acute treatment are the primary specific medications targeting the underlying cause or the acute inflammatory process of gout itself.
Okay, that clarifies the different roles. Now, osteomyelitis, that's a serious bone infection and can be a real challenge to treat, right? Expert, how would you precisely define this condition and what key clinical finding, maybe a vital sign, would make you highly suspected in a patient presenting with localized bone pain? What's that red flag?
Osteomyelitis is precisely defined as an infection of the bone. It's a very serious condition, typically bacterial in origin. Staph aureus is a common culprit, though other pathogens like fungi can sometimes be involved. It can develop rapidly after trauma or surgery, acute osteomyelitis, or it can smolder for months or even years, sometimes after inadequate treatment of an initial infection, chronic osteomyelitis. And you're right, it's notoriously difficult to treat effectively. This is largely because bone tissue has a relatively poor blood supply compared to, say, skin or muscle. This makes it challenging for antibiotics circulating in the bloodstream to penetrate and reach the site of infection in sufficient concentrations to eradicate the bacteria hiding out in the bone.
Poor blood supply makes it hard to treat.
Okay, exactly. Now, from a clinical perspective, if you suspect osteomyelitis in a patient presenting with localized, often severe bone pain, swelling, and tenderness over the affected area, one of the key systemic findings that should make you highly suspicious is a significant fever, often cited as above 101 degrees F or 38.3 degrees C.
Fever above 101 S.
Yes, this, combined with those localized signs of inflammation and pain, is a classic presentation of an active systemic response to a significant bone infection. While things like elevated white blood cell count and inflammatory markers like ESR or CRP also support the diagnosis, a high fever is a very direct and strong clinical indicator pointing towards an active, often aggressive infection needing urgent attention.
Okay. Given how serious osteomyelitis is, and sometimes difficult to treat, which patient populations are particularly at risk for developing it? Who should you, as a nurse, be extra vigilant with when performing your assessments and reviewing their medical history?
That's a really important question for prevention and early detection. You need to be extra vigilant for signs of osteomyelitis in several key patient populations, as their underlying conditions or lifestyle factors significantly predispose them to this severe bone infection. Firstly, intravenous drug users are at a significantly increased risk. This is often due to the direct inoculation of bacteria from contaminated needles or skin into their bloodstream. These bacteria can then travel through the circulation and seed themselves in the bone, often affecting the spine, vertebral osteomyelitis, or long bones.
Okay. IV drug users?
Secondly, patients with diabetes mellitus are highly susceptible. This is primarily due to a combination of factors: compromised immune function, poor peripheral circulation, especially in the feet due to peripheral vascular disease, and peripheral neuropathy, which can lead to unnoticed injuries. These factors contribute to the development of chronic, non-healing wounds, particularly diabetic foot ulcers, which are prone to deep infection that can easily extend down to the underlying bone.
Diabetes is a big risk factor then.
A very significant one, especially for foot osteomyelitis. And finally, post-surgical patients, especially those who have undergone orthopedic surgery involving hardware implantation like joint replacements or fracture fixation with plates and screws, or extensive bone manipulation, are at risk. Infection can occur at the surgical site and then directly spread to involve the underlying bone or the implanted hardware. Open fractures also carry a high risk. So it's not directly related to osteoporosis itself, but rather conditions that either provide a direct route for bacteria to enter the bone or severely compromise the body's immune defenses and circulation needed to fight off infection.
Got it. So, given how challenging osteomyelitis can be to treat, especially if it becomes chronic or involves resistant bacteria, what's the most severe, potentially devastating complication that patients with this condition are at increased risk for, especially if it's not effectively managed?
The most severe complication, and indeed a devastating potential outcome for patients with untreated refractory or chronic osteomyelitis, is amputation of the affected limb.
Amputation, wow.
Yes, because the infection can lead to extensive bone death or necrosis. It can be notoriously difficult to completely eradicate with antibiotics alone, particularly in chronic cases, or when blood flow to the area is severely compromised, like in severe PVD or diabetes. The infection can progress to the point where the affected limb or portion of the bone is no longer viable, is causing systemic illness, sepsis, or poses a constant threat of recurrence. In such dire situations, amputation may tragically become the only viable option to control the overwhelming infection, prevent its systemic spread, manage intractable pain, and ultimately save the patient's life or restore some function with a prosthesis. It's a stark reminder of the gravity of this condition It underscores the critical importance of aggressive, timely diagnosis and prolonged appropriate treatment. It's far more severe and directly linked than just developing a DVT or gout from the osteomyelitis itself.
Absolutely. A very sobering potential outcome. Okay, moving to another critical post-surgical scenario. After spinal surgery, like a laminectomy or fusion, you're on high alert for specific complications. What's one of the most concerning of these potential complications, and how would you recognize it specifically when assessing the patient's surgical dressing? What's that precise visual cue you're looking for?
Right, after spinal surgery, one of the most concerning complications you absolutely must be highly vigilant for is cerebrospinal fluid, or CSF leakage.
CSF leak.
Yes. This occurs if the duramater, that's the tough protective membrane covering the spinal cord and nerve roots, is inadvertently nicked or torn during the surgical procedure. CSF can then leak out from the spinal canal. To recognize this visually when assessing the surgical dressing, you would look for a very specific finding: clear or yellowish drainage that often exhibits a characteristic halo sign, especially if it's mixed with a bit of blood.
The halo sign? Can you describe that?
Sure, the halo sign is quite distinctive. You'll see a central area on the dressing that's stained, perhaps reddish or yellowish, from a mix of blood and CSF. But surrounding this central stain, there will be a lighter, clearer ring, like a halo. This clear outer ring indicates the separation of the watery CSF from the heavier blood components as it wicks outwards on the dressing material.
Ah, I see. The CSF spreads further out.
Exactly. The specific visual cue is quite distinct from simple bright red bleeding, which would be uniformly red, or purulent infected discharge, which would be thick, cloudy, maybe greenish or yellowish, and often foul-smelling. Even clear, watery drainage on the dressing without an obvious halo should raise suspicion for a CSF leak, especially if it's persistent or increasing. But the halo sign is a more definitive indicator when blood is also present. It demands immediate attention.
Okay, expert. So you've walked into the room, you're checking the spinal dressing, and you see that unmistakable halo sign, or even just clear, persistent drainage that looks suspicious. What's your absolute immediate nursing priority in that moment? What do you do first to ensure patient safety?
If you identify drainage consistent with CSF leakage on a patient's spinal dressing, especially that halo sign, your absolute nursing priority is twofold and immediate. First, cover the site with sterile gauze if it's not already adequately covered, just to maintain sterility. And second, without a moment's delay, notify the neurosurgeon or the surgical provider immediately.
Cover sterilely and notify provider immediately.
Yes. This is considered a surgical emergency or at least a very urgent situation. Applying sterile gauze helps protect the site from potential contamination and reduces the risk of meningitis, as the leak provides a potential pathway for bacteria to enter the spinal canal. And immediate notification is crucial because the surgical team needs to assess the situation promptly. It might require interventions like reinforcing the dural repair surgically, placing a lumbar drain, or specific positioning and activity restrictions.
So just putting more dressing on isn't enough.
Definitely not. Simply reinforcing the dressing without notifying the provider is inadequate and delays necessary intervention. Applying direct pressure is generally contraindicated, as it could potentially worsen the leak or affect neurological status. Elevating the head of the bed might be part of general post-op care or specific orders, but it's not the immediate definitive priority action for managing an identified CSF leak. The key is swift, protective action, sterile covering, and immediate clear communication with the surgical team.
Okay, crystal clear. Now, beyond the visual signs on the dressing, what's often one of the first symptoms a patient might subjectively report if they're experiencing a CSF leak after back surgery? What's that critical piece of patient-reported data you should be listening for?
Interestingly, and very importantly for your assessment, beyond just looking at the dressing, one of the first symptoms a patient might report if they are experiencing a CSF leak after spinal surgery is a severe headache.
A headache? Why a headache from a leak in the back?
It seems counterintuitive, but it's often described as a specific type of headache, a positional headache. This means it significantly worsens when the patient sits or stands upright and tends to improve, sometimes quite dramatically, when they lie flat. The reason for this is that the leakage of cerebrospinal fluid from the spinal canal leads to a decrease in the overall volume and pressure of CSF within the entire closed system, including around the brain. This decrease in intracranial pressure means the brain loses some of its usual buoyant support from the CSF. It can kind of sag or settle slightly within the skull, pulling on pain-sensitive structures like the meninges, which manifests as that intense, often debilitating headache, particularly when upright.
Wow, That's fascinating. So a positional headache is a big clue.
A very big clue. It's a crucial subjective report to listen for, as it can sometimes precede or accompany the visible drainage from the incision, providing you with an early warning sign of a potential CSF leak. It's not typically hypertension, nausea, or numbness that are the primary initial symptoms of the leak itself, although those could occur for other reasons. That postural headache is key.
Good to know. Now, shifting to the emergency setting, for a patient presenting with an acute fracture, say of a long bone, like the femur or tibia in the emergency room, what's your absolute nursing priority intervention? What's the very first non-negotiable thing you should be doing upon their arrival or as soon as you encounter them?
For a patient presenting with an acute fracture in the ER, particularly a significant one involving an extremity, your absolute nursing priority, the very first thing you need to assess is their neurovascular status distal to the fracture site.
Neurovascular checks again. Seems like a recurring theme.
It absolutely is, especially in ortho and vascular. Just as we discussed with PAD and post-op bypass, immediately assessing the circulation, sensation, and movement below the level of the fracture is paramount. Fractures, especially displaced ones or those with significant swelling, carry a major risk of associated nerve or blood vessel damage. This could be from the initial trauma itself, from bone fragments, or from rapidly developing swelling leading to compartment syndrome.
Right, compartments.
Exactly. By performing those meticulous neurovascular checks the 6P again, pain, pulse, pallor, paresthesia, paralysis, polar poikilothermia, coolness, you can rapidly detect any signs of compromised blood flow or nerve impingement. Catching these early is critical because they might require immediate intervention, like fracture reduction or even emergency surgery, like a fasciotomy for compartment syndrome, to preserve the limb's function and viability.
So assessment comes before anything else.
Assessment of neurovascular status absolutely comes first. Applying a heating pad is inappropriate for an acute injury. Restricting fluids isn't a priority. Elevating the limb might be part of the plan later, but only after assessing neurovascular status and ensuring elevation won't worsen potential compartment syndrome. Applying pressure is generally for bleeding control, not the primary action for the fracture itself, unless there's significant hemorrhage. That neurovascular check is job one.
Okay. Speaking of pain management for acute fractures, which often requires strong analgesia, is there a specific pain medication, maybe an opioid, that you should generally avoid giving to fracture patients due to its potential for serious dose-dependent side effects, especially in this population?
Yes, there is one opioid that is generally contraindicated or strongly discouraged for pain management in fracture patients, and that is meperidine, which most people know by the brand name Demerol.
The Paradigm Demerol, why avoid that one?
The reason's incredibly important for patient safety, particularly in patients who might need repeated doses or have any kidney impairment, which is common in older adults who are also prone to fractures. Meperidine is metabolized in the body into a substance called normeperidine. This metabolite is neurotoxic.
Neurotoxic.
Yes, meaning it's toxic to the nervous system. Normeperidine can accumulate in the body, especially if kidney function is reduced, and it can cause significant adverse neurological effects. These can range from tremors, agitation, and myoclonus, muscle twitching, to disorientation and even seizures.
Seizures, wow.
Yes. Given that orthopedic patients often require sustained analgesia, and the risk profile, potential renal issues, need for multiple doses, Demerol is generally considered a poor choice and is contraindicated for orthopedic pain management by many institutions and guidelines. There are far safer and more effective opioid alternatives available, like morphine, hydromorphone, Dilaudid, fentanyl, or oxycodone that don't have this neurotoxic metabolite issue. So avoid Demerol for fractures.
Good to know. Avoid meperidine and Demerol. Now, skeletal traction. This is a complex intervention used less often now, but still seen sometimes, perhaps for stabilizing certain complex fractures before surgery. It requires very specific and meticulous nursing care. Expert, what actions are appropriate for you as the nurse to take when caring for a patient in skeletal traction? What are your key responsibilities in managing this setup?
Caring for a patient in skeletal traction definitely demands precise and vigilant nursing actions to ensure the traction is effective in aligning the bone fragments and, crucially, to prevent serious complications. Several actions are appropriate and necessary. You should absolutely assess the patient's skin frequently, at least every 8 hours, paying close attention to all pressure points, bony prominences, and areas under straps or bandages to prevent pressure injuries and skin breakdown. Remember, their mobility is severely restricted.
Skin assessment, okay.
Performing meticulous pin site care is also critical. Skeletal traction involves pins inserted directly into the bone. These sites are a direct portal for infection. So you need to diligently clean the pin sites according to strict aseptic technique and your facility's specific protocol, assessing for any signs of infection like redness, swelling, warmth, or purulent drainage.
Pin site care to prevent infection. Got it.
And crucially, for the traction itself to work, you must ensure that the weights hang freely at all times.
Weights hang freely. What does that mean exactly?
It means the weights attached to the traction ropes must not be resting on the bed frame, the floor, a chair, or any other surface. They need to exert a continuous, uninterrupted pulling force as prescribed. If the weights are obstructed, the traction isn't working correctly.
Okay. And what should the nurse not do?
What you should not do is adjust the amount of weight yourself, for instance, if the patient complains of pain. Only the provider, typically the orthopedic surgeon, can order changes to the traction weights based on the specific fracture, healing progress, and X-ray findings. Your role as the nurse is to monitor the system, ensure it's set up and functioning correctly as ordered, perform the skin and pin care, manage pain, assess neurovascular status, and promptly report any issues or changes in the patient's condition to the provider. Don't mess with the weights.
Monitor, maintain, report, don't adjust weights. Clear. Now, a very serious, potentially life-threatening complication that you must always be aware of in patients with significant fractures, especially after fractures of long bones like the femur or pelvic fractures, is a fat embolism syndrome, FES. Expert, what specific findings, often appearing 72 hours after the injury, would make you immediately suspect this dangerous complication? What's that classic constellation of signs and symptoms?
Fat embolism syndrome is indeed a critical, potentially lethal complication that can occur after major trauma, particularly those long bone or pelvic fractures. Fat globules from the bone marrow can enter the disrupted venous channels at the fracture site and travel through the bloodstream. The classic clinical findings that should make you immediately suspect FES typically involve a triad of organ systems: respiratory, neurological, and dermatological. You'll often observe profound and rapidly developing hypoxia, a low oxygen level, low SpO2, low PaO2, that might be difficult to correct, even with supplemental oxygen. This is due to the fat emboli lodging in the pulmonary capillaries, causing inflammation and impairing gas exchange, similar to ARDS, acute respiratory distress syndrome.
Hypoxia. Okay.
This respiratory distress usually leads to tachypnea, or rapid shallow breathing, as the body frantically tries to compensate for the lack of oxygen.
Tachypnea. Got it.
The classic skin finding, though not always present, is widespread petechiae. This is a distinctive non-blanching, doesn't fade with pressure, reddish-purple pinpoint rash. It typically appears on the chest, especially the anterior chest and axillae, armpits, the neck, and sometimes the conjunctiva, the lining of the eyelids. This is thought to be caused by fat emboli damaging small capillaries.
Petechiae on the castexillae, that's specific.
Very specific when present. And finally, neurological symptoms are common due to fat emboli traveling to the cerebral circulation. These can range from acute confusion, agitation, restlessness, or drowsiness, to a decreased level of consciousness, focal neurological deficits, or even seizures or coma in severe cases.
Confusion or altered mental status.
Exactly. So that constellation of sudden respiratory distress, hypoxia, tachypnea, neurological changes, confusion, and potentially that characteristic petechial rash, that's the classic picture of fat embolism syndrome, demands immediate recognition, supportive care, especially respiratory support, and urgent medical attention.
Okay. Finally, just thinking broadly about postoperative care, after any kind of significant bone surgery like fracture repair, joint replacement, spinal surgery, what are some general expected nursing interventions you can anticipate performing as part of routine postoperative care for these patients? What's in your standard toolkit?
After any kind of significant bone surgery, you can definitely expect to perform a range of general nursing interventions aimed at preventing common postoperative complications and promoting optimal recovery. It's about proactive, holistic care. This includes rigorously encouraging the use of an incentive spirometer and deep breathing coughing exercises. This is vital to prevent common and potentially serious respiratory complications like atelectasis, collapsed air sacs, and pneumonia, which can easily occur due to immobility, pain-limiting deep breaths, and the effects of anesthesia.
Incentive spirometry. Keep those lungs open.
Exactly. You also need to be diligent about inspecting heels and other bony prominences for pressure injury. Patients undergoing bone surgery are often less mobile, may have splints or casts, and are at increased risk for skin breakdown, especially over areas like the heels, sacrum, elbows, and back of the head. Frequent repositioning and skin checks are key.
Pressure injury prevention. Crucial.
For specific joint surgeries, like hip replacements as we discussed. You'll likely use abduction devices, like the pillow, to maintain proper alignment and prevent dislocation. And of course, proactively assessing and effectively administering pain medication is absolutely essential. This isn't just about patient comfort and humane care, although that's critical. Adequate pain control is also vital to allow for early mobilization, participation in physical therapy, and performing those necessary respiratory exercises. Uncontrolled pain hinders recovery significantly.
Pain management facilitates recovery.
Absolutely. So respiratory care, skin care, positioning devices where indicated, and effective pain management, these are all integral components of comprehensive post-bone surgery nursing care.
Expert, let's talk about compartment syndrome again briefly, because it's such a critical orthopedic emergency that you absolutely must recognize immediately. Can you quickly recap the key findings, especially what makes that pain so distinctive, and reiterate its dangerous underlying pathophysiology that makes it so time-sensitive?
Absolutely. Compartment syndrome is a true limb-threatening emergency, and rapid recognition is key. It's often summarized by a subset of those 6 Ps we keep coming back to, with severe pain being the absolute hallmark and earliest sign. The key findings include pain that is unrelieved by medication, even strong opioids. This pain is often described as disproportionately severe out of proportion to the visible injury. It might be a deep, burning, or aching pain that just keeps escalating.
Pain out of proportion and unrelieved by meds, that's the big one.
That is the cardinal sign. As the condition worsens due to increasing pressure and ischemia, you might then see paresthesia, numbness, tingling, pins and needles, as the nerves become compressed. Later, and much more ominous signs include pallor, pale, dusky skin, polar poikilothermia, coolness of the limb compared to the other side, paralysis, loss of motor function, inability to move fingers or toes, and ultimately pulselessness, loss of distal pulses. These last 2 are very late signs indicating severe, possibly irreversible damage.
So you want to catch it at the pain paresthesia stage?
Ideally, yes. You don't wait for pulselessness. The underlying pathophysiology is critical to understand why it's an emergency. Compartment syndrome occurs when there's excess swelling or bleeding within a closed, unyielding fascial compartment, those sheaths surrounding muscle groups, common in the lower leg and forearm. Trauma, like a fracture, crush injury, severe burns, or even tight casts or dressings can cause swelling or bleeding inside this fixed space. Since the fascia can't stretch, this swelling rapidly increases the pressure within the compartment. This rising pressure eventually exceeds the pressure needed to perfuse the capillaries, compressing blood vessels and cutting off vital circulation to the muscles and nerves trapped within that compartment.
Pressure cuts off blood flow.
Exactly. If this pressure is not promptly relieved, usually by a surgical fasciotomy, it leads to prolonged tissue ischemia, irreversible muscle necrosis, death, permanent nerve damage, and potentially Volkmann's contracture, deformed limb, or even necessitates amputation. It's a literal race against the clock to restore perfusion.
Okay, so if a patient reports that severe, unrelenting pain, maybe some tingling, and you suspect compartment syndrome based on your assessment, what is your absolute immediate nursing priority? What's your very next action?
If you suspect compartment syndrome based on those clinical findings, particularly that escalating pain unrelieved by analgesia, your absolute nursing priority is to notify the provider, usually the orthopedic surgeon or emergency physician, immediately.
Notify the provider immediately, no delay.
No delay whatsoever. This is not a wait-and-see situation. It is a true surgical emergency requiring prompt evaluation and potentially definitive intervention. The definitive treatment is that emergency fasciotomy, where they surgically cut open the fascia to relieve the pressure and restore blood flow. Any delay in recognition and notification can lead to irreversible damage within hours. It's crucial to understand that actively elevating the limb is often contraindicated in suspected compartment syndrome, as it can further decrease arterial inflow. Applying ice might cause vasoconstriction and worsen ischemia. Loosening a bandage or a cast might be done if it's obviously too tight, but it's not the definitive treatment and shouldn't delay notifying the provider. The priority is immediate surgical consultation.
Okay, got it. Now, moving to a different area. After carpal tunnel surgery, carpal tunnel release, what's essential teaching you need to provide to your patient about their recovery, and crucially, when should they be concerned enough to call their provider back?
After carpal tunnel surgery, essential teaching focuses on managing expectations for recovery, wound care, activity modification, and importantly, recognizing signs of potential complications. The most crucial piece of teaching regarding when to be concerned is to instruct the patient, very clearly to report new or worsening pain, numbness, or tingling immediately to your provider.
New or worsening symptoms, why is that the key?
Because the primary purpose of carpal tunnel surgery is to relieve the compression on the median nerve. Therefore, the surgery should ideally alleviate their preoperative symptoms of pain, numbness, and tingling in the hand. New, severe, or worsening pain, or a return or worsening of numbness tingling postoperatively is a significant red flag. It's not expected. It could indicate potential complications such as nerve injury during the surgery, an infection developing in the incision, a hematoma, a collection of blood forming under the incision and causing new pressure on the nerve, or even persistent nerve compression if the release wasn't fully adequate.
So it means something isn't right.
Exactly. All of these possibilities require prompt assessment and potentially intervention from the surgical team. While some post-operative incisional soreness is definitely expected, new, severe, or escalating pain or worsening neurological symptoms are never considered normal after this type of surgery and warrant an immediate call. Expecting increased pain for weeks or avoiding all wrist movement indefinitely are incorrect and could hinder recovery.
Okay, great teaching point. Finally, let's address a unique and often challenging pain phenomenon, phantom limb pain. For patients who've undergone an amputation, expert, what kind of medication or perhaps class of medication might be used sometimes to help treat the specific type of pain that originates, seemingly, from a limb that's no longer physically there?
Phantom limb pain, where the patient experiences often distressing or painful sensations that feel like they're coming from the amputated limb, is indeed a fascinating yet often profoundly challenging phenomenon. It affects a large majority of amputees. Its exact mechanism isn't fully understood, but it's thought to involve complex changes in both the peripheral nervous system, at the stump, and the central nervous system, spinal cord and brain. Essentially, the brain's map of the body hasn't fully adapted to the limb's absence, and pain signals get misinterpreted or generated centrally. Because it often has neuropathic qualities, various medications targeting nerve pain are tried. One class of medication that may sometimes be used as part of a multimodal approach to treat phantom limb pain is beta blockers, specifically a drug like propranolol.
Propranolol, a beta blocker. Interesting. How might that help?
Well, while it's not typically a first-line treatment for all patients with phantom limb pain, and it's often used alongside other therapies like antidepressants, TCAs, SNRIs, anticonvulsants, gabapentin, pregabalin, or non-pharmacological methods, mirror therapy, TENS, beta blockers like propranolol, they've shown some efficacy in certain individuals. The proposed mechanism is thought to be related to their effects on the sympathetic nervous system and potentially central adrenergic pathways involved in pain modulation. It might help reduce certain types of cramping or burning phantom sensations in some patients. It's distinct from using something like allopurinol for gout, or even morphine, which might be used for severe pain but doesn't target the specific neuropathic mechanism as directly. Propranolol is one option sometimes considered for the unique challenges of phantom limb phenomenon. Treatment is often very individualized.
Okay, finally, let's just briefly touch on metabolic syndrome. While it's not directly a vascular, bone, or rheumatic condition in isolation, expert, it's increasingly relevant to overall patient health, and it often impacts or coexists with patients who do have the conditions we've spent this whole deep dive discussing. What are the key features nurses need to recognize that cluster together to define this important syndrome?
Yes, metabolic syndrome is incredibly important for nurses to recognize because it's essentially a cluster of conditions that, when they occur together, significantly and synergistically increase a person's risk for developing cardiovascular disease like heart attacks and strokes and type 2 diabetes. It's a major public health issue. For you to recognize it and understand its broad implications for patient health, you need to be able to identify its key features or components. There are typically 5 criteria used, and having 3 or more generally confirms the diagnosis. These key features include, first, abdominal obesity, also called central obesity. This isn't just about overall BMI, it's specifically excess fat carried around the waistline. It's often measured by waist circumference. 40 inches in men, 35 inches in women, though criteria can vary slightly.
Abdominal obesity. Got it.
Second, hyperlipidemia, specifically characterized by elevated triglyceride levels, typically 150 mg/dL, and conversely, often low levels of high-density lipoprotein, HDL cholesterol, that's the good cholesterol, typically 40 mg/dL in men, 50 mg/dL in women.
High triglycerides, low HDL.
Third, hypertension, or persistently high blood pressure. This is usually defined as a blood pressure, 4-key, 55, 85 millimilli Hg, or being on medication for previously diagnosed hypertension.
High blood pressure.
Fourth, high fasting blood glucose. This is typically defined as a fasting glucose level, 800 milli-GDL, or being on medication for previously diagnosed type 2 diabetes, This indicates impaired glucose metabolism.
High fasting sugar.
Exactly.
Yeah.
And the fifth component, which underlies much of this, is often insulin resistance. While not always directly measured, it's the state where the body's cells don't respond properly to insulin, leading the pancreas to produce more insulin initially and eventually contributing to high blood sugar, high triglycerides, and other metabolic issues. The high fasting glucose is often a marker of this.
So abdominal obesity, high triglycerides, low HDL, high blood pressure, and high fasting glucose.
That's the cluster. Recognizing this pattern of risk factors is crucial because it identifies patients who are at substantially increased risk for major adverse health events. Addressing metabolic syndrome often requires a multifaceted approach involving lifestyle changes, diet, exercise, weight loss, and sometimes medications to manage the individual components. It highlights the interconnectedness of metabolic health and cardiovascular risk. #outro.
Wow, expert, what an incredible, really in-depth, deep dive into these vascular, bone, and rheumatic conditions. You've truly helped us unpack essential symptoms, master critical assessments, understand vital interventions, and grasp the underlying rationales for so many crucial nursing scenarios.
It was great covering this, Grant. It's also interconnected.
Absolutely. And remember, for you listening, our future nurses, understanding these details, like knowing the 6 Ps forwards and backwards for neurovascular checks, or remembering the components of Virchow's triad for DVT risk, it isn't just academic, is it?
Not at all.
It's about being profoundly prepared to make those accurate assessments quickly, intervene appropriately, and provide truly life-saving care when you're faced with these complex situations in real-world patient settings.
And if we try to connect all of this to the bigger picture, it really becomes clear that true nursing mastery comes from more than just memorizing isolated facts from a textbook. It comes from deeply understanding the interconnectedness of these disease processes, how one thing affects another, and also learning to read those subtle, often nonverbal cues your patients are getting.
Those subtle cues.
Yeah. And this raises, I think, an important question for you, the dedicated nursing student listening today. How will you continue to actively hone your observation skills and your critical thinking abilities in your everyday practice? Beyond just what's needed for the next exam, how will you train yourself to truly see the full clinical picture and anticipate patient needs before they escalate into crises? Because the learning, it really never stops. And every single patient encounter offers a brand new opportunity for another deep dive into their unique presentation and needs.
That's a fantastic point. A great challenge for all of us. We really hope this deep dive has given you a clearer, actionable, and truly comprehensive understanding of these complex but vital topics. Keep learning, keep asking those insightful questions, both of your instructors and of yourselves, and keep making that profound difference in your patients' lives.